Okay, hello everyone. So this is um my concept map for my second um infection that I was given. So I was giving osteomyelitis. I didn't really know much about this until I was given it. So just off of looking at the name, we know that osteo has to do with the bone and then itis at the ending. So um, inflammation of the bone. Um, this condition can affect all individuals from any age range, and it can develop from a variety of causes. It's like open fractures, surgical procedures, bloodstream infections, and chronic wounds. Hopefully, by the end of my concept maps, you'll have a strong understanding of the pathophysiology of osteomyelitis, the risk factors, some signs and symptoms, some diagnostic testing, treatment options, and most importantly, the nursing responsibilities and interventions involved in managing and educating the patient about this infection. That was for my previous slideshow, but so this is a picture of osteomyelitis. Um, I don't know if this, well, it looks like the same wound. It just looks like it was left untreated for a very long time. So here in the x-rays, we can see a lot of that fluid around. When we look at the actual pictures, you're gonna have that really deep wound. Um, we'll have like the necrotic tissue building around that drainage. It's really, really thick there. Yeah, this looks insane. I'm sorry, I probably shouldn't say that, but yeah, this looks crazy, and I hope would love this. Um, but yeah, let's go ahead and get started. Okay, so here we have our concept map for osteomyelitis. So let's get into the patho. Osteomyelitis is an infection of the bone. Typically, the most common pathogen that's going to be present is Staphylococcus aureus. That is usually responsible for 80% of the cases of osteomyelitis, but it is going to be an infection of the bone marrow, and any tissue surrounding the bone. The bacteria is pyogenic bacteria, meaning it is pus producing. I didn't even know that was a thing, but apparently it is. And this bacteria can stem from a viral or fungal infection. It can occur anywhere in the body, um, but it mostly occurs in the long bones, such as the tibia, femur, and fibula. Once the abscess is formed underneath the periosteum, pressure is created, which can cause a destroy of blood vessels and create bone necrosis. So, if we're looking at that picture here, like we said in the patho, it's gonna cause a destroy of blood vessels, which is obviously gonna interrupt um, the blood flow in that region. So that's why we have that swelling here. It looks like this patient really didn't take care of this either in a timely manner. I don't know if that's like a normal thing. I don't know what's up with that, because it's like year ranges. Um, but anyway, you can see here, like in the x-ray, there's that fluid near the big toe, and we have that drainage. Yeah. With this infection, the bone tissue will become inflamed, swollen, and eventually overrun by the infection. Without proper treatment, circulation to the bone decreases, and it leads to chronic infection, necrosis, like I said, and even amputation in severe cases. Um, Osteomyelitis is kind of complicated because We have that cycle of like infection, necrosis, and the body is trying to heal, but it's kind of difficult because we have, if the necrosis and like all that dead tissue is not taken out, the infection's just gonna stay in that area. Okay, so for causes and systems, for causes of osteomyelitis, number one is primary osteomyelitis. This is going to be disseminated through the bloodstream when there is an infection in a different side of the body. Some examples of this can be infection from like pneumonia. And it can also be caused by a lower resistance to bacteria, such as a recent surgery. And then secondary osteomyelitis can occur from trauma, surgery, or sepsis, or when there is a break in the skin and bacteria is present. So, as we know, people who are really, really, really at risk for breaks in the skin are who? People who have diabetes, diabetes mellitus, because they have a higher risk to neuropathy, poor wound healing, and reduced blood flow, particularly in the feet. And as we know, osteomyelitis likes to be around those long bones near the feet, what we have here. Another risk factor is for people who have peripheral vascular disease. They have a reduced circulation and it limits the body's ability to deliver immune cells and antibiotics to the affected area. Also, too, people who are immunosuppressed. I did mention that in the primary osteomyelitis, it can be caused by a lower resistance, such as a recent surgery. But people who have immunosuppression, they have that constant lower resistance. So, patients who have like HIV, cancer, long-term corticosteroid use, or sickle cell, they could be at high risk for this. And then people who have chronic wounds, especially pressure injuries near like the heels of the feet, the calves, yeah, they're very at risk for this. Okay, so there are going to be some signs and symptoms that we want to look out for when a person does have osteomyelitis. Some of those include restricted AROM. Obviously, this infection is very, very painful, and because of that abscess that is formed underneath the periosteum, that's gonna hurt when a person tries to move. That's gonna hurt really, really bad. So sometimes the person will just try not to move as much, or they'll try to compensate, so they'll change their posture or the way they do their ADLs because of the pain. There's gonna be abrupt fever and fatigue. We have an infection, not only in the bone but in the body. So once we get that abrupt fever and fatigue, that's when we're gonna know at this point the infection has moved on to be systemic. It's not just staying at the site anymore. So we have a problem. We're going to see that redness, swelling, and tenderness. We have a lot of pressure, and the blood vessels are becoming destroyed. So that's where we're going to have that. We're going to have increased warmth. We're going to have pain or tenderness at the affected site. Like I said again, we have that pressure that's being built. We're going to have abnormal wound drainage. It could be yellow, green, brown, white, and may have a foul odor. And of course, if this is a sign and symptoms, we'll speak on this later about the assessment and the abnormal wound drainage. We have to remember this bacteria is a pyogenic bacteria, meaning that it is pus producing. So that's where we have that coming from. We could have muscle spasms, anxiety. This can be a sign and symptom due to this infection, like I said, being a little bit complicated, um, because of like the necrotic tissue, a patient can have anxiety if they notice their AROM is kind of diminishing and it's not as good as it used to be. That could be very, very scary. Or noticing that your uh, ability to perform like your ADLs is not as strong anymore. That can be really scary. You could have nausea um, due to the infection in the body, and then we'll also have vomiting. We know that when the body has something inside of it that it doesn't like, it's going to try to get it out. So, yeah. Okay, so diagnostic testing. Um, these are kind of like our go-tos, like our gold, yeah, like kind of like our gold standard for identifying if osteomyelitis is present. So we do have a bone scan. This is going to identify areas of infection and abnormal blood flow from the inflammation. And then a bone biopsy is going to identify organisms and bacterial sensitivity to antibiotics. This is going to be really, really important knowing what bacteria is present later on when we get to our interventions, such as giving antibiotics, because we just don't want to be, giving people medication that's not even going to affect the bacteria present. Um, and then also, too, you could also do like a wound culture, too, to see what is present in the drainage as well. So some abnormal labs that we're going to have is we're going to have a high white blood cell count. We obviously have a very present infection. So the body is going to activate the white blood cells to try to fight it off as best as it can. Um, and then we're going with that blood culture. It's gonna be positive, and this will positively identify which bacteria are present in the body. Like I said, this kind of goes hand in hand with that bone biopsy, knowing what we have going on in the body, so we're not just giving interventions that have nothing to do with the bacteria present. Okay, so what assessments are going to be made for a person who has osteomyelitis? So obviously, we're always going to start with our vitals. Specifically, one thing we really want to focus on is that temperature. Well, no, let me rephrase that. Really, we should be focusing on all of it, but to start, the temperature, we want to check to see if a fever is present. Like I said previously, a fever is an indicator that the infection is systemic. Um, we want to look for an increased heart rate. A lot of times when a patient is in pain, that can be an indicator of um, a lot of times when there's a high heart rate, it shows that a patient is in pain, as well as an increased BP. We want to gain patient history on previous bone traumas, injuries, or surgeries. Like we said earlier, those are two big indicators, or two big causes of osteomyelitis: surgeries, um, uh, cuts in the foot, any type of trauma. So that's really important. If a patient is coming in to the hospital with signs and symptoms of osteomyelitis, and you ask them like, "Hey, did you just get a surgery?" and they're like, "Yeah," that dims down a lot of the other infections out there, and you can make that connection. We want to assess for redness or swelling. A big, I guess, thing that you can do. Hope was mentioning like in 305 to use that marker that, for like the body, it's like obviously okay, but you can draw a circle around it to see if the swelling is progressing. We want to assess for a limited AROM, like we spoke on previously. That is also going to be another big indicator. They're going to try to compensate, which takes us into the observe the gait for any limps or abnormal gaits. As we know, the gait, when you do like, a musculoskeletal assessment, it should be smooth and coordinated. There should be no, limping happening unless, there's other issues going on. So that is going to be a big cause of concern if a patient is not usually like that. We want to look for foul smelling drainage from the wound. Depending on what kind of drainage is present, we don't want to have blood coming out. We don't want to have like yellow. That's always going to be a sign of infection. We want to check electrolytes and monitor I's and O's for signs of dehydration. Of course, with this fever and this wound drainage happening, we're losing a lot of fluid from the body. And if surgery is needed, we're also going to be losing fluid from blood loss. So we do want to make sure that the I's and O's are equal and we're replenishing anything that is being lost. And then we do want to run a blood test, like we mentioned before, to see if the white blood or, any abnormalities in the labs, such as the high white blood cells or the positive blood culture. And then also too, like we mentioned before, a big risk factor is for people who have diabetes. We want to make sure that we are really assessing them, specifically on inspection and palpation, because they do have reduced pain sensation. So they might not even be able to like let us know if they are in pain or what's going on. How do we know that they can even see their feet? So we really need to make sure, because what if they don't even know that osteomyelitis is happening near the long bones of their body? Okay, so I guess we'll get into our medications. So as we know, we do have a bacteria present. So a lot of the medications are going to be to get rid of the infection, aka antibiotics. So I'm really sorry if I butcher these names, but we have nafcillin, ceftriaxone, cefazolin, and ciprofloxacin. A lot of these interventions that we talk about are really, really dependent on the bacteria that is present. So with that, the dose will be dependent on the bacteria that is present. Excuse me. The drug's purpose is to kill bacteria and decrease the spread of infection. Some all the other interventions that don't have to do with medications or prescription medications include additional therapy like heat therapy and distraction for pain. The nafcillin, you're gonna give intramuscular IV. It's gonna be 1 to 2 grams every 4 to 6 hours, and you will need to reconstitute and add 3.4 milliliters to each 1 gram vial. Ceftriaxone is going to be IM/IV for most infections, and it's going to be 1 to 2 grams every 12 to 24 hours. You're also going to reconstitute IM doses with sterile water for injections or 0.9% sodium chloride injection. Cefazolin is going to be for moderate to severe infections, 500 milligrams to 1 gram every 6 to 8 hours, and severe infections is going to be 1 to 1.5 grams every 6 hours. Okay, so let's get into our nursing diagnosis. So the first one, number 1, is the risk for the spread of infection. We don't want the necrotic tissue to continue to the rest of the body, so we do have that risk of the spread of infection. So our diagnostic statement, would be number one, risk for spread of infection related to the presence of bacteria. Some solutions for the risk for the spread of infection, the antibiotics, a lot of the ones that we just went over previously. We're gonna have surgery to remove the drainage and the removal of the necrotic tissue and that possible spread of infection. Um, so the surgery, like I said, will be the removal of the necrotic tissue, irrigation, which is like flushing the area to remove the bacteria and debris. We're gonna drain the abscesses. Um, and if it's really, really, really severe, amputation might be needed if they're not able to resolve the necrotic tissue. Typically, excuse me, typically, post-op, the doctor will place a splint to decrease pain and promote wound healing. So this can kind of go for both of our nursing diagnoses for the risk of the spread of infection and impaired mobility. But ultimately, the purpose of the splint is to have those screws in place of the limb, of the bones, and to make sure that it stays in place. So when the patient is moving, um, there's like no issues, and it decreases the pain. Um, we know that nutrition is very, very important post-op, and just really we want to be have like a nutritional diet to fight off the risk of infection. So we want a diet high in calories, a diet high in protein and vitamin C to promote wound healing. Like I said previously, for the surgical interventions, there could be a drainage of the abscesses. So if an abscess is present, the doc will place a catheter in the wound for irrigation. Um, we also want to make sure that we're not adding to the infection. So we want to make sure that we're doing proper wound care. As nurses, that is a responsibility, but it is our responsibility to educate the patient on how to take care of their wounds once they are discharged and they go home. So we want to make sure we're following that sterile technique in the hospital when placing our dressings. So use sterile technique when placing a sterile dressing to avoid contamination. Um, we want to wash our hands, apply our clean gloves. We want to make sure we're removing all of the old gauzes. We don't want to just keep piling up gauzes in the wound. We want to make sure we are applying sterile gloves. Um, uh, we want to clean with a sterile wound solution. We want to dry with a sterile gauze. And then we want to apply a new gauze. So our smart outcome will be that patient's white blood cell count will be within normal limits with no abnormal drainage within 48 hours. As we said, that high white blood cell count is an indication that an infection is present. Our second nursing diagnosis statement is impaired mobility. Really from the start, like we said, a sign and symptom is of osteomyelitis is that decreased AROM. So even before interventions are applied, they're having that issue, but also post-op, during that recovery, they're gonna have impaired mobility while they're still healing. Uh, and then So our diagnostic statement is going to be impaired mobility related to decreased ROM secondary to bone infection, as evidenced by reduced movement of the limbs during musculoskeletal assessment. And that's why I mentioned in the assessment section, we want to make sure that we're fully assessing our patient as far as like the movement of their joints and their limbs. That's going to be super important. And some impaired mobility solutions. Like I mentioned previously, the doc will place a splint to decrease pain and wound healing. This splint holds the bone in place and allows a reduction of pain and swelling. Um, this will be really important when the patient is able to become mobile. We want to limit as much pain as possible to kind of alleviate that fear that if they remain mobile, like pain will occur. Like we just don't want that to be the situation. We want them to feel like, okay, if I move, my leg will start to feel better. So whatever is necessary to make that patient feel comfortable with movement. And then we also want to collaborate with physical therapy to improve ADLs and range of motion. Really, you shouldn't even be like trying to collaborate with the physical therapist post op. Um, that restricted AROM is a sign and symptom of osteomyelitis. So, you should be collaborating with them as soon as possible to let them know that there is decreased range of motion. Um, we, of course, want to frequently reposition the patient post-op to avoid contractures. We should be repositioning the patient every 2 hours anyway, but it's very, very important because the patient is post-op and we just want to reduce any further uh, body issues. Um, we want to educate the patient on wound care, and we want to educate the patient on adhering to the antibiotic regimen. Um, a lot of the time, I know I'm very, very big on doing this. I'll have an infection and I'll start to take my medicine and I feel way better, so then I'll just stop. But that's just because the medication is doing its job. You need to make sure that the patient is adhering to the antibiotic regimen so that the infection doesn't occur again. And so our smart outcome will be the patient will present 5 out of 5 AROM and a balanced and coordinated gait within 4 days post-op. And this smart outcome is attainable because if you are collaborating with physical therapy and moving the patient as much as possible, you can get them back to good health. Okay, so excuse me, some rationales. So for number one, I did connect the high white blood cell count from the abnormal labs and the abrupt fever and fatigue. And I did put that the body will start to show signs of systemic infection, such as fever, malaise, sweating, nausea, and vomiting, due to there being a harmful bacteria in the body. To compensate, the body will increase in the amount of white blood cells to fight off the infection. Number two, I did connect the diagnostic test. I'm so sorry, I'm like losing my voice. And, excuse me, the antibiotics. Um, and a bone biopsy identifies the bacteria present in the bone and the sensitivity to certain antibiotic. As antibiotics are a key intervention for this disease, it is important for a bone biopsy to be done to pick the right antibiotic for the certain bacteria present. Like I said, we don't want to just be giving our patient random antibiotics. We want to make sure it's the correct one. And then for number three, again, that's that assessment on getting patient history on previous bone traumas, injuries, or surgeries, and that being one of the primary causes of osteomyelitis. It is going to be very important to ask about any previous bone traumas, injuries, or surgeries during your initial assessment, as having a low bacterial resistance is the primary cause for osteomyelitis. Number four is that checking for electrolytes and monitoring I's and O's for signs of dehydration, and that abnormal wound drainage, such as the yellow, the green, the brown, the white, with the which may have the foul odor. There's going to be a constant flow of abnormal wound drainage will be present. It is important to monitor the patient's electrolyte levels and eyes and nose for signs of severe dehydration due to sensible and insensible fluid loss. And some interventions for that would obviously be giving the patient, making sure that they have adequate fluid, making sure that if they need electrolytes, that the physician tries to order something via IV if they can't take oral fluids. Number 5 is that connection between the antibiotics and the redness, swelling, and tenderness and the increased warmth. Interventions such as antibiotics and sterile wound dressings will directly address the current infection, thus removing the signs and symptoms of systemic infection and removal of the present bacteria. And then number 6 is that patho of the abscess is formed underneath the periosteum, and the pressure is created, and it creates a bone necrosis, and that has to do with the restricted arom. Once an abscess is formed underneath the periosteum, it will cause the destruction of blood vessels and necrosis. This will lead to pain, redness, tenderness, and swelling. Due to these obstructions, movement will become painful and lead to limited arom.